Good afternoon, everyone. I'm Anvesha Pandey, Deputy Director at NATEL, and I'm so excited to be back again to cover yet another aspect of the Ayushman Bharat digital mission. This webinar series, as you all know, is being organized jointly by NatHealth and with National Health Authority. We've been running this series since November, and almost every week we have an eminent speaker come on this platform and share their insights on one aspect of the Ayushman Bharat digital mission. We've already covered many areas like on insurance, design, architecture, etc. And today we will be discussing unified health interface. And to discuss this topic, we have a very eminent speaker with us today, Mr. Kiran Gopal Vaska. He's an officer of the Indian Administrative Services, currently working at the National Health Authority as Director Digital, and is responsible for policy, IT, and adoption of the Ayushman Bharat digital mission. He holds a bachelor's degree in computer science and engineering from IIT Bombay and a master's degree in advanced economics and international development from Harvard University. In his earlier roles, he's worked in areas of power, rural development, health and family welfare, education, industrial development, etc. Before joining the government, he worked in the finance industry. Very warm welcome to you, sir. We also have with us Dr. Simardeep Singh Gill. He is the Chief Executive Officer of the C.K. Birla Hospitals, and he will be moderating today's session. In his present role, he manages Calcutta Medical Research Institute, B.M. Birla Heart Research Center, both in Kolkata, and Rukmini Birla Hospital in Jaipur, and is responsible for the overall operations of these three hospitals with a bed strength of approximately 900. Dr. Gill has almost 20 years of experience in the healthcare industry. A very warm welcome to you, sir. So, I'll request both of you to please take this discussion forward. Thank you so much.
Thank you, Anvesha.
Thank you, Anvesha. Dr. Gill, you being the moderator, I'll follow your lead.
So I believe let's do one thing. Do we have enough participants to start the presentation? Because that's something which is
yes.
The axis of the entire conversation.
Yes, so we are actually live streaming on our Facebook and YouTube platforms, and we would have number of participants. Yes.
Let's do the presentation first. Let's spend the next 15-20 minutes on the presentation, and then subsequently have a dialogue around and then take questions also.
Thank you, Dr. Gill. I'll just share my screen. Yeah, so I hope it's visible. Is my screen visible?
It is visible.
Okay, great. So I'll give a very brief presentation about what the universal health interface is and what the idea is about and where we are currently at, and what is the kind of challenge we are trying to address through this health interface. The first slide, this is like just to give you an overview of what ABDM architecture is about and where this whole universal health interface is going to fit in this entire architecture. This nice block diagram that you are seeing in the middle of this presentation, it is read bottoms up. So at the very bottom layer, you can see that we have what we are calling JAM and other digital public goods. These are basically Aadhaar for verification purposes, UPI for payment purposes, e-sign again for authentication, DigiLocker. As you can see, it is where people will put the digital documents. A consent artifact, which is at the core of the entire document sharing and retrieval mechanism. So basically, ABDM leverages upon all these technologies that have been already made available by different agencies of the government. On top of this, you see the health data layer, which is basically the main registry and that stores all the information, such as information of health IDs, the healthcare professional information, the health facilities information. There is the drug registry coming up, so the drugs related information. And then we have the health information exchange and consent manager, which manages the consent for moving documents from one provider to a user. And then there are certain standards that we are building for health claims, etc., etc. So on top of this sits the universal health interface layer. So this is the layer we'll be discussing more in detail today. So this is the layer that actually is going to solve that problem of interoperability that today does not exist currently. And if I were to give a very crude example, because crude or rather a minimalistic example, it would be something like UPI, where you are on Google Pay and you are paying someone through who is on Paytm. So this kind of interoperability is what we want to achieve through universal health interface, and I'll talk more about it. And on top of this is where the user applications will come in. While the bottom three layers is where we will be playing, that is the government is going to play a major role in developing and maintaining this. On the topmost layer is where we will have more public and private partnerships and innovations in this, because this will have individual applications, HMIS, lab management information systems, etc., etc. So this is how the whole architecture is, and as you can see, unified health interface plays a very, very important role in this whole ABDM stack that we follow. So what are the key challenges that UHI tries to address? First thing, India lacks standards and infrastructure for health that enable accelerated adoption of digital health services. In fact, that is the point we were discussing with Dr. Gill just before this meeting. I mean, there have been computerization. I mean, it's not that you won't find a computer if you go to a hospital. There is a computer even in some of the remote districts of the country. But then how well are these used? Is the entire service digitized? And how are we utilizing these digital services, and how are we digitize this service delivery mechanism? And as we all know, maximum doctors or specialists are sitting in the bigger cities, and the cases are somewhere in rural areas. How can we leverage our existing technology, the communication technology, so that these services can be provided to far-flung areas in the country? And COVID-19 also has given us an opportunity to and has made us understand the importance of enabling digital health services, where we were desperately looking for hospital beds. We were desperately looking for drugs available, like remdesivir is one I know. When we were in the States, I mean, we had desperate calls from people asking for vials of remdesivir. Oxygen, I mean, we all know what happened there. And then booking, I mean, ideally, I mean, like finding right from beds to also booking for vaccinations, etc., etc. And then ultimately fulfillment of services. I mean, using of telecommunication, teleconsultation. I mean, people have used these in various forms to help people who are, let's say, in home isolation, etc., etc. So COVID-19, although was a very bad experience for us, it also gave us an opportunity to look at afresh at this whole health service mechanism, delivery mechanism. But then the challenges that we have are the ecosystem challenges, which is, like I mentioned earlier, the non-standardization of processes, lack of digital records for accurate delivery through digital means, because most of the cases we have are X-rays or prescriptions, etc., in the form of big stack of files, and there's no digital record of it as well. And on top of that, the technological challenges is how do we engage these two people? I mean, today we know that there are platforms like 1mg or Practo, etc., etc. But then they are like, you have to be on Practo to talk to a doctor who is on Practo. So there are those limitations, and it is all fragmented. So the idea is to have a decentralized, inclusive, and open network that will spur this adoption of digital health services. I mean, we expect this to be an enabler for adoption of digital services. So then that is where we are saying that we will have to have open networks. So what is an open network? Here we take a simple example of email. For email, all of us know that somebody has an account on Google, somebody has it on Yahoo, somebody has it on Rediff, etc., etc. But then I can always communicate, right? Simply write an email from my Gmail account to someone who has a Yahoo account. And how is this possible? It is possible because there are these routing nodes, the red ones, you can see, which actually work on open protocols. I mean, if in fact for email, it is SMTP, Simple Mail Transfer Protocol. So this is an open protocol that was made available, and every email client actually subscribes to this and adheres to these standards. And the beauty of this network is it is open, accessible, and there is no single owner for SMTP. It is a public good. It's for everybody, and it is interoperable, and nobody mandates that you have to have a Google email ID to send a email to a Google email ID. No, it's like you can send it from anyone to anyone. So that is exactly what we want to kind of achieve through UHI in the health domain. So in the health services network, you will see, for example, the left side is what is currently existing. So platform one would be a teleconsultation or a home visits app. You have to be on that platform to be able to avail that service. Similarly, an online pharmacy, you have to be you have to have that online pharmacy application with you on your mobile or use it on computer, and the pharmacy also needs to be on that computer, have registered on that. And similarly for appointments, etc. What we want to do is to move to the right side of this slide, where we say that we will link anybody to everybody through these open protocols that UHI will help us. So that is basically how we envisage the health services to look like, or in the future. So who are the stakeholders and how this whole UHI is going to work is what we are trying to show here. On one end, you have patients. In fact, I would replace patients with, let's say, citizens, because you need not be a patient to avail a health service. A pregnant woman is not really a patient, actually. So we have citizens on one end who want to access some digital service. They are using any application, which we are calling an end user application. They send their request to the UHI, which is a gateway based on open protocols. And these are then relayed to what we are calling health service provider applications. They could be any. I mean, a simple example is there is a couple who have a child, and the child has an earache. And it is like 12 o'clock in the night, and now they are desperately looking for a doctor. So they have an application already which they are using. But then maybe there's no doctor on that application who is currently available on that platform. What this UHI will help you is, it will actually help you search other platforms also, and help you. I mean, it'll relay that message, get the search the entire database of whoever is available, and then show it to you in this application. And it basically makes what you call connects. It's like a one-to-many connect, and sometimes even a many-to-many connect. So that is how this UHI gateway is going to work. And the technology service providers who are important stakeholders in this are the providers of these applications. Tomorrow, somebody might develop an app which is like completely interoperable and does this. Again, to give the UPI example, a technology service provider there is Paytm or PhonePe or Google Pay or Amazon Pay or something like that. So, and they are like on both ends. You are like, for example, you visit a hospital. Let's say you visit Ram Manohar Lohia Hospital. Ram Manohar Lohia Hospital uses NIC's e-hospital software. So e-hospital software, it not only creates records and it not only generates records, it also utilizes records from other hospitals and other softwares to provide the service. So basically, what we are trying to say is, this gateway is the one that will break, that is expected to break these barriers of these platforms and make services more available to the people. So how would a typical technological teleconsultation journey through UHI look like? One would create a health ID. I mean, an application would be integrated, and that would be a very simple process. Then you log on to the end user application. Then you do a search. You simply say orthopedician who speaks Marathi. Then the system will throw out the search results of who is available along with their specializations and the prices they are charging. And then you do and also the available slots. You do the booking and do the payment, and then you give and then at the time when this appointment is scheduled, you give a consent through your application that yes, my previous records could be shared with this doctor so that he can view them, and then he or she can give me the consultation, and finally after consultation the prescriptions, the discharge summaries, etc., they are all automatically available in your application. So this is how it is envisaged to work. So this is how a typical user journey would look like through this whole open networks principle. So again, this question of again, Doctor, the discussion we had with Gil was like, we are the entire health, the ecosystem is really in kind of a nascent stage as far as digitization is concerned. How do we move ahead and how do we leapfrog? Some idea, and unlike, let's say, UPI, banks were already computerized. Core banking was already a part of it. We were all doing online transactions even before UPI had come. So computerization there didn't seem like a major challenge. Here, we are still used to carrying our physical records. We are still used to taking that physical purchase to the medical shop to get the medicines. And then we are still used to getting that physical X-ray in our hands and the doctor looking at it against the light, etc., etc. So how do we move? So first, from the patient-provider engagement side, we are saying that in the current state, patient and provider need to be on the same application. UHI will break that barrier and say that any application to any application, you are able to do that. Price discovery, again, it becomes more transparent because now you are able to look at multiple options through multiple service providers and multiple platforms. And continuity of care, complex cases which require different specialities, which involve integrating medical advice of visiting multiple doctors. UHI can actually help you get a group consult also. You can actually have an end user application that enables group consult through UHI. So this is how we are saying that this whole leapfrogging can happen. So what is happening at NHA in terms of building the UHI and where we are at? So what we did with unique thing about UHI is we said NHA will not impose any restriction on what protocol to be used or what how these specifications will look like. We are saying we will use open community protocols. In fact, there is a GitHub community of developers which is developing these protocols, and NHA is only adopting the protocols. So tomorrow, as the use cases increase, as more and more people start using it, the specifications will get refined, added to, and we will get newer versions of specifications which are owned and developed by the community. So this is where we are saying that is how we are ensuring that everything is open and there's no what you call platform dependency on it. And the UHI gateway is something we will build based on these protocols. So NHA will build this UHI gateway where protocols are open and everybody knows what the protocols are. And it is only like a very thin layer that enables communication between two entities. And UHI sandbox is what is like a sanitized environment where anybody who wants to use UHI will first test themselves on the sandbox in order to ensure the safety and security of the data. And once they pass the test, now they are part of the gateway. So the protocols version, one version is ready. We are actively on the development of the gateway. And personally, I am looking at a couple of weeks where the first version of the gateway also should be available. In fact, we are planning a hackathon sometime in April. And we would be opening up many challenges and on innovation and integration challenges where we expect a lot of developers to come in and pitch in and develop more and more APIs and applications onto this. So this is exactly where we are right now. And in terms of having a first version of UHI up and running and open for the public, I'm looking at a couple of months maximum where we'll probably have a first version run. That would be probably a very light version when we'll slowly start building on top of it. So that's how what we are doing. And the ABDM registries of ABHA, that is Ayushman Bharat Health Account Number, the Health Professional Registry and Health Facility Registry is what we will be leveraging. when I search for a doctor or when I search for a hospital, these registries are what we will be looking at. So looking forward, how we see what's going to happen. Like I said, we'll have a validation phase where these protocols are validated for their integrity and security. And then we want to have the hackathon, and we are also coming up with a network policy, which will actually define how different players on UHI network will interact with each other. This is to enable A, transparency, and B, openness, to make sure that any transaction that happens on UHI network, any interaction that happens on UHI network adheres to certain standards. And scaling up is like we are trying to do a targeted adoption of activities industry-wide and adoption of more and more refined protocols. And then the idea is, as the service grows, we will have network effect where more and more people will come in and more services get added. And that is how this gateway gets implemented. And we are also open to the idea of having multiple gateways. Tomorrow, some entity might say that, okay, I can develop a gateway which has an additional or some new encryption model or something. So we are also open to that. So this is how basically we are looking at how UHI development and its implementation is going to happen going ahead. So I think that is all I had to say. And I think I would now give the baton back to Dr. Gill to take the discussion forward. And thank you for listening to the presentation. And I'll just stop sharing my screen if that is okay.
Sure. Thank you so much, Kiran. This is extremely, besides being insightful, I think it's extremely exciting. And I'm waiting for the day when all of this will fall into place. This is going to dramatically change the way we do healthcare in India. I've got some questions, so let me. So we've got. We can make a difference using voice technologies in the mission. It'll allow people to connect millions of people at a time using voice artificial intelligence. Do you think it should be becoming a part of this mission?
Yeah, that's a very good question. See, I mean, this is where I would say the fundamental work of what's happening in NHA as part of ABDM would come in. What we are saying is, we are only building very core blocks, and how the different players will interact, what value added services one gives, whether one uses an AI chatbot or one uses machine learning to improve diagnostics, etc. If you remember the topmost layer I talked about, the end user applications. So these applications are the ones where these kind of automated voices or using of Autobots or AI enabled systems can come in. And what the UHI is going to do, it's only going to be that bridge. I mean, let's say, for example, tomorrow someone comes with an application that can guide me. Let's say I'm using a particular application and an end user application, and I have a certain problem. It could be anything. I mean, I'm experiencing some abdominal pain or whatever. Now I can select or search for somebody based on these particular symptoms, and the system can throw up, okay, these are the options you have available. One of the options can be this automated voice system, where UHI will now allow me to connect to that particular system. And then the communication is happening between me and this system. Now then the system asks me questions. The Autobot will ask me questions. Okay, which part? Is it the left part or the right part? And how is it? Is it a stinging kind of a pain or a dull pain or anything, and any other symptoms and any other things that it might ask? So it is very much what you call a part of what we envisage. And what we are saying is, we are creating enablers. You can use, It could be like you can probably take a picture of me and upload it, and then if there is an automated AI system which can scan the picture and tell me, oh, there is some problem with you, even that is possible. So I mean, it is very much possible, and there's no restriction on what technology can be used.
But I'd just like to add to what you said. There might be some medical legal implications here, and within our context, with different states having very different regulatory laws, this could be under a bit of a cloud on that count.
Right. Again, the very important point you mentioned. That is why we have a legal team, which actually, whenever we are building and releasing new building blocks, we have what we call a HDM policy, the health data management policy. So how health data can be used and for what purposes, and we make sure that it is used as per extant laws. Is it be the PDP bill or any other medical legal? In fact, for example, there is a 1972 act, the Medical Termination of Pregnancy Act, I think, which prohibits even creation of ID or mentioning of name wherever medical termination of pregnancy has happened in, let's say, a juvenile.
That's right. Yeah.
So we are also looking into those aspects and making sure that these are integral part of our policy framework. So when I said we are coming with the UHI policy, UHI network policy, the idea is we are trying to incorporate all these and make it part of our data management and also network administration policies. So that's the basic idea.
Yeah, no, that's good. In fact, wherever consults and clinical opinion comes in, medical legal suddenly drops in.
Yes.
So you'll have to take care of that even from an AI perspective.
Right, absolutely.
The next question is, kindly share details on ABHA creation and capture and verification for seamless patient registration.
Okay, great. Again, I mean, although it is like what you call it is in fact one of our core building blocks. See, ABHA creation is like you registering for, let's say, an email ID. It's as simple as that. How do you create an email ID? You go to Google, it asks you some basic details. Then it tries to authenticate whether, let's say, it asks you for a phone number, then you get an OTP, and then you type the OTP, and then your email ID gets created. And if you are a child, and if you try to create that in Google, and if, for example, if you give your date of birth where it shows that you are less than 13 years of age, then there is again, it will drive you to a section where it says, okay, this is where parents will fill the information. So basically, it is as simple as that. So you can use the NDHM app that is available on Play Store. You can use eSanjeevani. You can use Paytm. You can use, I mean, you can in fact visit a hospital where you are just attending a hospital, and if you give them your Aadhaar or driving license, these are the two KYC documents that are being asked. And if you give them the Aadhaar, you'll get an OTP on your mobile number, and then once you share the OTP and you give your consent and the Aadhaar, the ABHA number is created. And if you're doing it yourself using an application, or you can in fact go to our website, abha.abdm.gov.in, where you can generate your health ID. The URL may be slightly different. One might want to check. So those are different ways of creating generate ABHA. So it is healthid.ndhm.gov.in. So if you go there, you can generate your ABHA using Aadhaar, or you can generate your ABHA using driving license. In fact, if you would like, I can just simply share my screen and show how it looks like. So this is the page. So this is the page. So it is healthid.ndhm.gov.in/register, where you go to generate ABHA and create your ABHA. So you can generate it using your Aadhaar, where you click it, you give your Aadhaar number, and you say that you agree to creation of this and using your Aadhaar number, and then the next is as simple as creating an email ID. So this is a very, very simple and straightforward way of creating the ID. And as far as retrieval and registration is concerned, in fact, one of the things we are working on is coming up with a QR code standard. For example, let's say you have an ABHA number and I don't have an ABHA number. And you go to a hospital and I also go to a hospital. So now what is the advantage that you have by having an ABHA number if we both have to stand in the same queue? So what we are coming up is, we are working with all these patient, what do you call the PHR apps like Paytm and Ayogya Setu, etc., where we are saying that the hospital can simply put a QR code outside for that counter. You scan the QR code with the application, and then your data is automatically entered into a registration system, so that you don't have to like stand up in queue. So there is a difference between someone who has an ABHA and someone who does not have an ABHA and who have to go through the regular route. So these are the kind of some benefits that one can have apart from the whole linking of records, availability of digital records, etc. So we are coming up with the QR code policy. So just like you go to a thela wala or a sabji wala and then you scan the Paytm code or something and make a payment, you can do a similar thing, and you can register yourself. Similarly, retrieval of records also is possible. Let's say you are visiting a hospital and you are going for a what you call second visit, what you call referral, or what do you call follow up. Yes, when you're going for a follow up, you don't have to go through all this. You straight away go to that particular area and then you simply scan that QR code and your details are going there. So these are certain benefits one would get, and this is how we are saying that seamless exchange of information will happen. That's the idea.
Our next question is, how will ABDM help grassroots health issues in India?
That is probably like what you say, one of the fundamental questions that we are trying to answer, and that is what this whole idea is about. If you remember, one of the things I was telling about doctors being available in cities and not being available in rural areas, but then we have diseases prevalent across the country, across all over the country, even in remote areas. So it is not impossible, but then it is too expensive to move the doctor to the rural area or the patient to the urban area, and the time that you would take will probably not make sense and probably may not be very useful. So what we are trying to do, and this is exactly where the universal health interface is going to come in, is today, in fact, we were reviewing one application called, there are health and wellness centers spread across the entire country. What happens there is, a patient goes, he or she need not have a smartphone. I mean, in fact, that is what the grassroots may, this is also another thing. I mean, is it only for people with smartphone, or is it only that I should have all these things? Person need not have a smartphone. He or she goes to that center. They have a system there and they register you. And if you have an ABHA number, the registration is quicker and your record linking happens very quickly. And we are integrating that software so that when they try to do a consultation, what in the current model, what is it like? They have a hub where there are some number of doctors sitting there, and then this consultation happens and they get a receipt which is given to the patient. What UHI will do is, you do not even go to that center. It could be someone in your locality who has a smartphone, or for example, when we all did not have phones, there used to be PCO at every corner. So what was the purpose of the PCO? That person had a phone, you went and put a 1 rupee coin, you called. There were also STD booths everywhere. So what UHI will do is create this market across the country for anybody to have this kind of a setup where you come, log in, you give your details, and then you are then able to interact and talk to multiple specialists across the country, whoever is registered in the HFR and whoever has made his or her services available. So from a grassroots point of view, what we are saying, this whole teleconsultation is actually going to play a very, very major role in at least providing the initial care. I mean, if somebody needs an admission, ultimately they would have to be brought to the hospital, but let at least the primary care and the initial care that needs to be taken. That is one thing that this probably the UHI will be able to address. One more thing is, today there is no concept of a citizen or a patient-centric view or a citizen-centric view of what you call records. In the sense, let's say there are various government programs that are running. One of them is, let's say, RCH, the Reproductive and Child Health Program. They are actually addressing pregnant and lactating mothers and infants. So when let's say there is a pregnant woman in a particular community and I want to go and give her services as an ANM, I do not know her medical history. What ABDM will help you is, let's say that woman is also, let's say, undergoing treatment under NHA program, which is a tuberculosis program. This ANM will have access to the fact that this lady had TB or currently has TB. So whatever service she is providing to this particular lady will be different. It will be tailored to her current circumstances rather than being that lock, stock, barrel kind of a service that I am otherwise doing. So this way, the whole preventive healthcare thing is also going to come in, where you are not waiting for some things to come up. Maybe she did not know that she was also a NHA beneficiary, or she was an NCD beneficiary where she had diabetes or some other problem. So the treatment, the whole protocol would change. So that's another point through which this whole thing is going to get addressed. Lastly, a lot of policy making and decision making today requires information and data and analysis, the data on epidemiology and how a particular drug is, efficacy of a particular drug, its side effects, etc. When anonymized and aggregated data, if it is made available for research purposes and also for policy making purposes, our schemes, policies, and interventions will be much more informed. So whenever, let's say tomorrow, there is a new program that is being designed for reducing, let's say, malnutrition, you actually will have access to a wealth of information that will inform your policies much better. So basically the idea is, it is expected to break the barriers of that are currently existing, the physical barriers, by enabling teleconsultation. B, it will help the creation of these longitudinal health records that will make healthcare delivery more better. And C, it will enable making of better policies, better schemes, and better programs. So this is how the idea, it is expected to address some of the challenges that we are currently facing.
Interesting. Okay, the next one is, what do you feel will be the role of insurance/reinsurance companies in this mission?
Very, very interesting, and I'd say something that is also asked and discussed here, and what is going to happen and what is the kind of role. See, what would happen, I think, in my opinion, is insurance or what you call availing an insurance today is like a tricky affair. There's information asymmetry on both sides. I am not aware of what kind of what you call insurances data is available. There are things like Policy Bazaar, etc., where you can go and there is an advertisement ki policy compare kariye fir lijiye. But what we are saying is, by this information being available, see, what is the cost of insurance? The insurance cost increases when the insurer feels like he does not know much about you. Therefore there is a risk. Therefore, he'll try to price that risk. When information, not necessarily my personal information, let's say the insurance company has information of all people who are my age, my work profile, and my background, etc., he will be able to assess my risk in a better way. And therefore, I think pricing will become much more what you call balanced, and that will probably bring down the whole cost of transaction cost that is being done. I mean, for example, NHA also implements the world's largest health assurance scheme, the PMJAY scheme. The beauty of the scheme is the scale. And right now we are not operating on the kind of information that we should have had. And right now, even the hospitals that are using this information are participating in this scheme, probably they will definitely benefit from all this additional information. And this whole trust factor, I mean, whether the insurance, I mean like, if for example, tomorrow I want to go buy an insurance, whether the insurance company, with my consent, can have access to information easily, rather than sending his people to look out for me and whatever has happened to me, etc. So this transactions cost will probably we can come down, and I think the trust factor will improve, and I think overall this could improve the way health insurance market works. That's the idea.
Okay. Our next question is, any updates from NHA concerning the pilots UHI is running? And it will be great to know if there are some inputs on the outcomes.
Okay, see, UHI has had no pilot as yet. It is like the gateway is yet to be built. So there's no UHI pilot that has run. In fact, like I said, our expectation is to come up with the gateway in a couple of weeks from now. Then we will build those what you call the use cases of trying to book an appointment from one application to another completely different application, trying to have a video consultation from one application to a completely different application. So then we will have the hackathon where we will invite all the startups, all the new tech companies, etc., to come, add on, learn, teach us also in the process, and then enrich this gateway further. So I think if I were to call it a pilot, the hackathon and the implementation that we are going to do as part of hackathon would probably be the pilot. Maybe 2 months down the line, probably I'll be able to update you.
Couple of months down the line, we should.
Yes.
Okay. The next one is, one of the most important use case will also be prevention and prediction of conditions for the citizens through this huge data collection. Now, will this also be under the scope? Now, this is a very interesting and a very good input.
Okay. First thing, regarding data, one thing I want to make very clarify or what you call demystify about how data is going to be dealt as part of ABDM is, we are one of the core principles on which we are working is what we are calling a federated architecture. So under federated architecture, we are not going to store data in a single place. I mean, my health records, if I go to, let's say, RML hospital, and RML hospital has a software and it has a cloud storage, my records will stay there. Tomorrow, if I go to Medanta, Medanta has a software, the records of Medanta, my records of that are created in Medanta will remain in the cloud or wherever Medanta is storing. The reference application, the PHR application that I have, will only give me linkages to these records and I can view them. And tomorrow, let's say I go to Apollo and Apollo requires access to these two records. I can give permission to Apollo, okay, ठीक है, मेरा RML का record ले सकते हैं आप, मेरा Vedanta का record ले सकते हैं. So this is how first place is how data is built. Now, how do you do this whole analytics, etc., on this really distributed kind of data? The idea is to have anonymized and aggregated data. So one may not really look at, okay, Kiran Gopal went to this hospital, his age is so much, he had this problem. No. Information such as a male aged 30 years or 35 years had a certain ailment, was given a particular drug, and this was the result. So this is like, you cannot really find out who the person is. So information like this can be gleaned. Again, this whole consent framework in this, we are also taking consent of the patient, saying that your information could be used exclusively for research purposes, but that too only anonymized. It's not like your name is going to come out, or you will not be, nobody will be able to pinpoint that, okay, this information belongs to this person. So the idea is to use this kind of information. And like I said, policy making, epidemiological studies, things like drug resistance, etc. I mean, if the particular drug is being given somewhere, another particular drug is given somewhere for the same kind of ailment, if the results are better somewhere, this could be better informed, and probably the whole doctor community can get access to this kind of information, and this will probably be used in changing. Let's say a particular drug or an antibiotic is being used excessively in some particular area, and that would create resistance to that particular drug. So this information, this anonymized aggregated information will be used, and this information is the one that will help us in making decision. It will help us in decision making. It will help us in improving our policies and making it better, and it will help in what you call the whole. I mean, like, we are also having a drug registry work that is going on in parallel, and I can only imagine how much this information is going to help in managing this whole drugs thing in a much more better way. So the idea is to have anonymized, aggregated data, and analysis would be done on that. And going ahead, it could even be available for research purposes, where people could use this for doing various studies. So that is how this data is going to be used.
Thank you. Okay, so far, last question. There are provider categories like doctors, pharmas, labs, hospitals, stem cell banks, etc. Will UHI classification address all these components? Can a patient access the entire ecosystem through UHI?
Yes. See, basically, when we look at these core registries, there are three. One is the ABHA, which is otherwise also called the Health ID. One is the HPR registry, which is the Health Professional Registry. And the third one is the HFR registry, which is the Health Facility Registry. So ABHA, as you all know, is like for individuals. The Health Professional Registry is one where we are going to capture information of all health professionals, which includes doctors of all kinds of medicine, Ayurveda, Unani, Siddha, the modern medicine, etc. We will also include the paramedical workers, ASHA, ANM, Anganwadi. We will also include people like lab technicians, radiologists, etc., etc. So this is where this is one information. The second one, the HFR, the Health Facility Registry, is where we will be registering all health facilities. And by health facility, I mean every hospital, which could be like a simple clinic. And then this is exactly where UHI, I'll come back to that example again, how UHI will help. It could be a very small clinic somebody runs at his home, to 100,000 or 200, 300,000 better hospital also. Labs, imaging centers, and anything that is wellness centers, yoga centers, or natural healing centers that you have. So the idea is to register all these facilities. Now, what will happen is UHI, once, let's say you are using an application which is connected to UHI, and UHI in the background is connected to these registries. So there is a search functionality that will give as part of UHI, and when you search for, let's say, naturopathy healing, it will go and hit the registry and give out all the details of those who are actually registering themselves as naturopathy medicine providers. So, and this is an example where I'm giving of UHI again. UHI, one of the things that UHI will help in doing is actually break the barriers of entry. For example, like I was collector in a couple of districts, and there people come and there is a request generally made that, okay, we have our son or daughter-in-law or son-in-law, they have just graduated from medical college, and they want to serve in the district hospital. No, we don't want any salary or anything. They just want to go and sit there and do work for a couple of hours. Why are they doing it? They actually are doing it because they want to tell people that, okay, there is a new doctor in the market. So they have a hospital, then they'll probably come up with a hospital or a clinic or something. What UHI does is, these doctors like these can actually register on the health facility registry and make themselves services available. So when I search for a doctor, he also will be visible. So that way, I'm actually able to find newer doctors, and I'm going to, maybe this is a new doctor and he really wants to, and he'll probably charge lesser, and because he's trying to establish himself. So things like UHI, the UHI is actually also going to give a platform to all these newcomers also. So again, coming back to the original question, these registries are the ones which are holding all this information, and NHA will maintain this, and you will have access to this entire plethora of information through UHI.
So there's a related question which has come up just now. It says, so an ecosystem and not a patient-centric model has been chosen for the HPR. I don't think that's right, because what you just said is again a patient-centric model.
See, I mean, to the person who has asked this question, what is a patient-centric model? See, patient-centric model is like, for example, whenever I want to provide a particular health-related service to that particular individual or patient, am I able to access all the relevant information regarding the patient so that the service that I am going to give to him is complete in nature? In the sense, it takes into account all his contraindications, all his previous experiences, previous cases of illness or any other complications, any other information that is relevant from a medical perspective. So that is what. Otherwise, what is otherwise happening is, like, there is a program called for a particular thing like control of blindness. So I am going searching for people who have Motia Bind, and I'm continuously going and operating them on Motia. I mean, there could be multiple reasons why Motia Bind is coming, and when I am going to treat a particular patient, if I have access to information other than that person has a Motia Bind, probably my treatment would probably be different than what I was doing. I mean, you as a doctor probably would know better. But what I am trying to say is, UHI and this whole ABDM building blocks and the construct of ABDM is to provide this kind of information to healthcare providers, so that they are able to cater to the service. I mean, so that they were able to really understand what this person needs from a holistic point of view. That, I believe, is the whole patient-centric model. That
absolutely right. We've got a couple of more questions. When will the consultation paper on the drug registry be released? Dr. Gedam, during his session in November, had said it would come out in a month.
I think it actually had to go multiple iterations, and my colleague Vikram Pagaria is currently involved in that. I don't think I can give a date because I am directly not involved in that work. But from the current work that is going on, I think it should be coming out very soon. That is what I can say, because I'm not directly involved in the work.
Sure. Next one, will there be a cost for using the UHI gateway? What is the incentive for any business entity to go through the UHI gateway? Please also consider peer-to-peer computing for UHI.
Okay. First thing, as of now, we have absolutely no plans of putting any charges for using UHI. This is going to be for free. I mean, for now, even we are not thinking of any charges. And what is the benefit for people to come on to UHI? One of the benefits is like what I already described to you. For someone who is an entrant, let's say there is you just built a new nursing home and you want to advertise it, and you want to make sure that people are aware that this is there. This UHI platform, UHI will give you a platform to register yourself and make yourself available. And if I know that, okay, this is a nursing home which has these qualified doctors, and there will be also this what you call independent rating mechanism that we will try to put in, and ratings, reviews, etc. Idea is to provide a platform and break that barriers entry barrier. Another one is, while one might be thinking that कि अरे ये interoperability होने से मेरा captive patient जो है वो कहीं और चला जाएगा, one must realize that कहीं और से आपके पास भी आएगा. So it's not a zero-sum game. I mean, people will be going, maybe they might be going somewhere. For example, I have both Zomato and Swiggy installed on my app, on my mobile phone. So I see that, okay, sometimes I order here, and if I'm not getting here, I'm sometimes ordering there. Imagine if I had an application where both are available and I can order from both the places. So it's like, if somebody is moving away from you, somebody is going to come to you also. It's not that unless you are really, really bad, that people want to run away from you. So
fair point. Absolutely.
So that is the idea. And I didn't understand the peer-to-peer point. It is in fact ultimately peer-to-peer. We are the gateway. You are at one end. There is an API you are communicating to. The service provider is at the other end. He is communicating to us through an API. And then it is ultimately between you and these two entities. This is effectively peer-to-peer. So I think that hope clarifies it.
Okay, so the next one is UHI a global first? Does any other country have this UHI sort of a thing in its framework?
Not as we know of. I think UK tried, but it wasn't very successful apparently. But I mean, it's kind of a global first only.
That will be great.
I mean, we really hope to once this is working, we will, and like I said, because this is a completely open protocol and open system, our objective is to make it available for anybody who is interested. Like UPI is being currently used by some foreign countries. Similarly, we really hope that UHI, although we are also we are able to offer. COWIN is being used by some countries. So similarly, UHI also will be able to offer to other countries. And this is, yes, kind of a global first. And definitely first for a developing country.
That's certainly very interesting. So that's all the questions we had, and we pretty much run out of time also. Anything on a closing note, Anvesha, Jayata?
I mean, maybe I can add just one more. To all those who are participating on this platform, what I want to tell you is about the GitHub community. Like I said, we are all working on open protocols, and this protocol development work is happening in a very open manner. Anybody can come. You could be a developer who want to add to the specifications and protocols, or you could also validate one existing protocol. So you can actually contribute and be part of this whole development process. I mean, I'll just share my screen to show the GitHub page where this whole work is happening. I suggest that you please go to this GitHub page. You can register. You can look at what we have developed. See, this is the DHP, the Decentralized Health Protocol Specifications, where we have different modules for what you call booking ambulance, booking an appointment, etc., etc. So as you can see, the DHP specification 0.7.1 is currently available. So this will keep coming up. So I request everybody to join the GitHub page, contribute, evaluate. If you think there is some new use case that we are missing, you can tell us. And there is a it is like Tomcat, Apache, Tomcat server or Linux, etc., where you contribute, you give your ideas. It is evaluated again by the community only. NHA will not say we will take or not take. The community will say that, yes, this is an important thing, this needs to be taken up. And that is how the specifications and the protocol will come up, and we will adopt that. So you can actually be part of this, part of building this whole thing, which is of what you call, like Dr. Gill said, and one of the questions was about this is global first, where we are actually building it with collaboration with the community. So you're all welcome to come and join this DHP GitHub page. Thank you.
That was brilliant. I was like really so much learning for me. I really enjoyed your session, Dr. Vaska. And Dr. Gill, thank you so much for coming on this platform and, asking such relevant questions. So I thoroughly enjoyed, and I assume, and I'm hoping that the participants who have joined this session, who are watching us live, would have also enjoyed this session. You know, in case we were not able to answer your questions, we have a blog which is called natalseries.com, and we can answer your questions there. We shoot those questions to NHA, and NHA reverts with answers, and we post it on our blog. I also want to make an announcement that tomorrow we have another session with Dr. Kiran Anandam Pillai on the integrators aspect of it. So please join us at 4 p.m. And in case, this session, you were not able to watch the session live, you can also watch the recording of this session, because we will be posting it on our social media channels. So thank you once again. And it was lovely to have Dr. Kiran and Dr. Gill, both of you, on this platform. Thank you so much.